Thank you very much. I'd like to thank you for giving me, the organizing committee, for giving me this opportunity to talk about, you can hear me is it working? Oh, yeah, now it's on, yeah. Cancer is, as you know, is a DNA disease. It is a disease that's caused by mutation. And these mutations can be driver mutations or passenger mutations. Now, the mutations in the early driver mutation, we call them trunk mutation. Then as the cancer grows, there are branch mutations that are not involving each cells in the cancer. So the trunk mutation involve most of the cells, and where the driver mutation are, then we have the branch mutation that involve subset of tumor cells. Now, because there's a mutation, and if a mutation is will cause new proteins, new antigens, and the immune system should recognize that, because the immune system will recognize the self from non-self. And that's why we have reaction in transplant, we have reaction in viral infection. They recognize self from self. So if that what's happening, then immune system should eliminate all cancer cells from the beginning. But this is not the case. There are many impediments to effective anti-tumor immunity. That's why the tumor grows and become clinically relevant. Many tumors antigen are self-tolerant because the tumor cells are coming from the tissue. Weak cancer patient immunity. But what is important is tumor microenvironment, and it was presented elegantly this morning, the session about PD-L1 and how this PD-L1 suppresses the tumor microenvironment. So although the patient with cancer is immune competent, but the tumor microenvironment is immunocompromised. And that's the whole concept of immunotherapy. So there are two ways to support the immune system with that. Enhancing immune system by vaccination, adaptive T-cell transfer, and stimulating factor, and so many research is going on that, and CAR T-cell is one of them. I think there was a talk about this. And we are building GMP facility at King Faisal at the King Abdul Cancer Center. It will be finishing in 2 years. And the reason is to produce these immunotherapies and cell therapies. One of them is CAR T cells. And really this is taking out of my time and my interest on that. Then this is one way, enhancing immune system. The other way is the unleashing the immune system. The immune system is there, you are not enhancing them, but you are helping the immune system to identify the tumor cells. Because the tumor cells, they evade the immune system. So you are uncovering the tumor cells for the immune system. So with immunotherapy, we are not enhancing the immune system. It's just helping the immune system to identify the tumor cells. And there are biomarkers, and it was discussed, PD-L1, CTLA4, LAG4, and the tumor mutation burden. So this is the immunogram, and has all the different biomarkers that is being used to guide immunotherapy in immuno-oncology. One of them that my talk is about is the microsatellite instability. So these are the practical ones. Tumor mutation burden that Dr. Turki will talk about. I'll talk about microsatellite instability. These are for tumor antigen. Then a tumor microenvironment, the PD-L1 and T-cell infiltrate. It was elegantly presented by our colleagues this morning. Then tumor immune suppression, LAG3, which is a new marker. So microsatellites are repeat of DNA, 2 to 5 nucleotides. They are repeat, it's part of the DNA polymorphism. 2 to 5 nucleotides, they are repeated in the DNA, and the mismatch repair system is DNA integrity system that will keep the stability of genome during the cell division. So these are the proteins that maintain the integrity of system during DNA replication. And it was observed that when there is deficient, when the MMR are deficient, this is associated with high number of somatic mutation. And this is one of the studies shows there are hundreds of fold increase in mutation comparing if the MMR are proficient. So, somatic mutation may lead to the expression of high number of tumor neoantigen, as I mentioned, that could promote the release of pro-inflammatory cytokines that will lead to recruitment of the cytotoxic T cells. So, when there is high number of mutations in the DNA, that will lead to high number of neoantigen in the cell, recruiting a lot of T lymphocytes to the site. So this is all associated with the microsatellite instability high. So the tumor mutation burden and neoantigen, and I'm not going to discuss how we are testing because Dr. Turki, he will talk about that. This is important area. When there is so much mutation, as I said, there's a new antigen. Now, the high mutation burden, high mutation rate, it occurs in two settings. When there is environmental exposure, like ultraviolet light in melanoma or smoking a cigarette, this one setting, and when there is microsatellite high. So in these two conditions, we have high mutation burden. In MSI, so in MSI high, we are testing the tumor mutation burden. When there is high mutational tumor mutation burden, there means there is recruitment of the T lymphocytes. And when there is the other setting is in lung cancer and in melanoma or esophageal cancer, there is environmental factor, ultraviolet light or smoking and so on. So in these two settings, there is high mutational burden, and we are testing in solid tumors, it is single nucleotide substitution. Mostly, more than 90% of solid tumors, single nucleotide substitution. So what we are testing the missense and nonsense mutation. Missense and nonsense mutation, and whether it is tumor mutation load or burden or MSI, it's the same concept. So it was found that an association between mutational load and response to immune checkpoint inhibitor was observed in first study for immunotherapy. So MMR status of a tumor may be assessed either by immunohistochemistry, it was presented before, there is loss of MMR protein, or PCR-based assay. You know, the MMR protein are tumor suppressor genes. And the tumor suppressor gene get inactivating mutations. Oncogenes get activating mutation, means expression more. So if you are testing for ALK, which is oncogene, so the test is positive. By positivity, the stain is there. But if you are testing for a tumor suppressor gene, it is inactivating the mutation, so loss of testing. The protein won't be there. And this is the general rule of the tumor suppressor gene, inactivating the mutation as opposed to activating mutation for oncogenes. And the other way is PCR assay for microsatellite instability. Now, these are comparable, so we don't have to do them both. In many institutes now, because pathologists, they prefer tissue, we use immunohistochemistry. It's the same concept as ALK. When we had ALK, we used to send it for fish till immunohistochemistry came, and now we rarely send for fish, only positive cases to confirm the diagnosis. So as pathologists, we prefer immunohistochemistry. We don't prefer to send for molecular because molecular is not under control of pathology. He cannot see the tissue. In the beginning, we used to send for PCR, for microsatellite instability testing, but now we rarely send, only for questionable cases. So mostly we use microsatellite instability now for colorectal cancer in our testing in our institute. It is the third most common cancer worldwide. 10.4% of all cancer in Saudi Arabia, mostly common in male, and third most common in females. In our data at King Faisal, it is third common after breast and thyroid in females. 2 to 3% of colon cancer is caused by hereditary factor defect. As you know, there are 3 pathways for colorectal cancer: chromosomal instability, there are mutation, APC and so on mutations, there are microsatellite instability, and CpG island methylation. So we'll focus on microsatellite instability in colon cancer. 15% methylation, epigenetic, and 5% mutation means germline mutation. And that's why we are testing for microsatellite instability. So for colorectal cancer, we are testing for MSI in all cases for the following reasons. It's not only to know the pathogenesis of colorectal carcinoma, it's important. Microsatellite instability is part of pathogenesis of colorectal carcinoma. But we are testing to see the screening for Lynch syndrome, also prognostic, because it's associated with good prognosis, and for a predictive marker. It's predictive for both chemotherapy and immunotherapy, for both. So these are the reasons. It's one of the few markers that is diagnostic, prognostic, and predictive. So MSI, so important to test. And some hospitals and some centers, if they don't have MSI tissue to test MSI, they repeat the biopsy. Is that important for the patient? Now, I tell you we'll go through the algorithm of testing. So MSI colon cancer is right-side colon cancer, poorly differentiated lymphocytic infiltrate, often mucinous, better prognosis, and sporadic 15%, HMBCC, Lynch syndrome 5%. So this is how we go by testing. By immunohistochemistry, we test the 4 antibodies, and loss of staining is the marker. So if there's loss of staining of MLH1, we have to do BRAF mutation. If the others, we do the germline mutations. If they are positive, then we don't have MSI. They are collating with MSI high. So we have 4 antibodies, we test, and we check them by immunohistochemistry. And the immunohistochemistry for MLH1 is straightforward. Once you have the antibody, it's not difficult. Lymphocyte or stromal cells must show nuclear staining. Cytoplasmic staining is not specific, and they are coming two in together, MLH1 and PMS2, MS2 and MS6. As I said, if there's MLH1 negative, means it's positive staining, then you do BRAF to make sure it's not sporadic. Most of them, they will be 85% will be sporadic. BRAF, we do BRAF mutation by PCR. It's interesting to know that BRAF mutation, like KRAS, indicates in colon cancer indicates poor prognosis, poor outcome. But when BRAF mutation associated with MLH1, with MSI, no, good prognosis, because MSI, microsatellite instability high, is associated with the good prognosis. So when BRAF is associated with microsatellite instability high, it reflects good prognosis. As opposed if it's alone, it's poor outcome. Now, in Saudi Arabia, in our studies, we had studied 500 cases for BRAF. And we have our percentage of BRAF mutation is low. In the West is about 10% BRAF mutation. Ours is about 3 to 4% in 500 cases. I don't know why, but maybe because we are having more cases of Lynch syndrome, and these are not associated with BRAF mutation. And also our cases of left side colon cancer is more. We have 85% of our cases left side colon cancer as Lynch syndrome, and microsatellite high are right side colon cancer, as I mentioned. So more cases of our cases are more in young patient and more left side early but the stage is most of our cases 70% stage 2 and 3. So the stage is the we reviewed 500 cases, most of them stage 2 and 3. So this shows lower side is nuclear stain positivity, upper side is the negative, means negative stain means it's positive marker, because as I said it's a tumor suppressor gene, so loss of staining, and you have the lymphocyte and plasma lymphocytes and stromal cells as inbuilt marker. So it's for pathologists is an easy immunohistochemistry stain, but sometimes it's questionable. So when it's questionable, we do PCR, the microsatellite, especially, or if it is the result does not match the clinical setting, then you do PCR. So these are the two. If it's questionable or the result doesn't go with the clinical setting, it should be MSI high, then we confirm, we do the molecular. So it's not only colorectal cancer, endometrial carcinoma, gastric, and many other cancer. So we will have more and more requests for microsatellite instability testing from different cancers, because as biomarkers for immunotherapy. Now, when we do molecular testing, we compare normal and tumor tissue, so part of the normal colon with the tumor, and it's easy to test. So I'm not going to do, because I have only 20 minutes, how we do STR. So we use 5 microsatellite, 2 are mononucleotide, PAT, and the other 3 D2 are dinucleotides. So if we have abnormality in one of them, is microsatellite low. If we have abnormality in 2, it's microsatellite high. So at least you have to abnormality in 2. So what we do, we run the tumor and the normal, and we are using capillary electrophoresis, the genetic analyzer, capillary electrophoresis. We run them together, and we compare by size. Of course, it's capillary electrophoresis. They run by size. And if one is abnormal, low and stable is the same. So microsatellite low, instability low, and MSS microsatellite stable is the same. We lump them together. It's the high, microsatellite high correlate with the negativity in immunohistochemistry. So if one of the stains is negative, one of the 4 stains are negative, it correlates with microsatellite high. And 2 of them should be abnormal to call it high. So in our study of 500 cases of colorectal carcinoma at King Faisal, we have 54 were high, which is 10%, 11%. This is by PCR, not by immunohistochemistry. We did a study in 2008 by immunohistochemistry, and it was 150 cases, and we published it in Annals, and it was 16% of our cases MSI high, 16%. In this study, we did PCR, and it was about 11%. Remember that as the tumor getting higher stage, the MSI get less number. It is in early stage. So if you, it is only 5% of stage 4 MSI high in colorectal cancer. So we say overall it is 15%, but when you are speaking about stage 4 colorectal cancer, only 5% are positive for MSI. So here we are talking about all the stages, 500 cases, stage 1, 2, 3, and 4. Most of our cases were stage 2 and 3, about 60 to 70% of the stages, 2 and 3. So we had 11% high by BCR. As Dr. Khalbas mentioned today, because of the high MSI high correlate with high mutation rate, high tumor mutation burden, and it recruits T lymphocytes. And recruitment of T lymphocytes, that's why they respond better to immunotherapy. And it's all together. And so MSI testing or tumor mutation burden testing or PD-L1 testing is just the same. It's correlation with the mutation rate, mutational burden. Recent study evaluated PD-L1 expression in MMR deficient endometrial tumors, either Lynch syndrome associated or sporadic, showed significant higher PD-L1 expression compared to the MMR proficient. So PD-L1 expression correlated in endometrial carcinoma, correlated well with the MSI. Okay. So this is my last slide because of time. MMR deficiency has been observed in about 4% of metastatic colorectal carcinoma. We are speaking about stage 4. 11% of ovarian carcinoma, 18% of endometrial carcinoma, and 1% of pancreatic carcinoma. So my message from here that you will get more different tissue. We are not testing different tissue, but we will receive different tissue because immunotherapy has been approved for different tissue if it's MSI high. Thank you very much.